عليكم. First of all, as usual, it's a great pleasure to be in such an esteemed conference and to be invited from dear professors, mentors, and friends from the NCI, and to attend such well-organized conference. My second real pleasure is to introduce my friend and one of the best GI oncologists in the Arab world, my dear friend, Professor Shawi Mazarbachi. As I was telling him, he started with the rectum and started to go up and up. He's now talking about stomach. I wish he would stop there. Now he is giving us a lecture about an approach to borderline locally advanced pancreatic cancer in the era of FOLFIRINOX and gemcitabine nab-paclitaxel.
Bismillahirrahmanirrahim. Thank you, Mr. Chairman, and all the chairpersons. It's a pleasure and honor for me actually to be here. And I know I have a difficult task now after hearing the lecture of Dr. Kosmidis with all the good results from immunotherapy in lung cancer. Now I have to talk to you about one of the most difficult cancers to treat, which is pancreatic cancer. So this is where I come from. This is our new cancer center, where we are hoping to move soon if our budget allows. So when we talk about pancreatic cancer, looking at SEER data from the USA, we're talking about this group of patients with a 5-year survival of about 10%. If you remember from Dr. Kosmidis' one slide, the lowest survival ever was pancreatic cancer, 5-year survival 2%, and that's with metastatic disease, and this is the same over here. We're talking about the group which are locally advanced, not readily resectable, and we have at present time a 5-year survival of 10%, and they represent about 1/4 of the patient population. And the locally advanced are grouped under two groups, either borderline resectable or locally advanced unresectable. I want to tell you that borderline resectable, it's very difficult to actually separate it from the locally advanced. If you look at the literature, there's a lot of phase 2 trials. They're best described as garbage literature. You don't reach any conclusion. There is very little randomized trial in the locally advanced borderline resectable. There is no consensus on how do you find the borderline resectability. In the trials, we do have now some consensus. And there's no consensus on what adjuvant therapy has been used. So if you look at the trials, you see people have used radiation therapy, chemoradiation, and different types of chemotherapeutic agents, as you can see. And most of all, they have been lumped into either the locally advanced unresectable or sometimes with the resectable pancreatic cancer. So I'm not going to waste your time to look at how we define resectability or the borderline resectable, but now, yes, we do have a consensus, and this consensus is actually adopted by the NCCN guidelines. I don't think we need to remember them. What you need to remember is the resectability is defined by the interface between the tumor and the vessels. So you have the tumor here, the vein and the artery, and as long as you do have actually a clear plane between them, then the tumor is resectable. Once you have no clear plane, then you go into borderline resectability. And once you have a 180-degree involvement of the vessel, then that's an unresectable. This is very simplified way of looking at it. Of course, it's much more complicated, and I don't mean to step on the surgeon's toe in this regard. So if we want to look at the borderline resectable, the best way to look at it is to look at the largest meta-analysis that was actually done, which was published about 5 years ago. And you can see 111 studies, about 4,400 patients. They were the meta-analysis included patients who had both resectable cancer and borderline resectable, and that's what I mean by they're always lumped into a bigger group. You can see that neoadjuvant chemo was used in about 96% of the studies, and the neoadjuvant radiation in 93%. So the majority of the patients had received both chemotherapy and radiation therapy. Now, the numbers that I want you to look at, first of all, this group are the resectable one, and this group 2 are the borderline resectable. And you can see there's a significant difference between the exploration rate. So here in those resectable, 88% were explored, while in the borderline resectable, only 46% were explored. The response rate was equal in both, 3.6 to 4 complete response and partial response about 30%. What I wanted to look at is about the resection rate in the borderline resectable was 33%, and out of those, 79 were R0 resection. So if you want to calculate how many had an R0 resection from the total, you would see that in borderline resectable, with neoadjuvant chemo radiation therapy, we have about 26% R0 resection. And that's what counts in pancreatic cancer. And I want you to keep in mind this figure. So what's best? How can we tackle patients with unresectable pancreatic cancer locally advanced? We have different ways. You can either give them systemic chemotherapy, or you can give them chemo and radiotherapy, and that can be either upfront or following a period of chemotherapy. And what I'm trying to prove to you now in my talk is that systemic chemotherapy is probably the way to go, and there is little place for radiation therapy. So those are 2 randomized trials, one of them from France and one of them from the US, and both show very contradicting data for locally advanced pancreatic cancer. In the French trial, patients were randomized to upfront chemoradiotherapy, which is the lower curve, versus only chemotherapy in the upper curve. And of course, in this trial, there was a survival advantage for giving single-agent Gemzar, chemotherapy alone, as compared to chemoradiation. In the US ECOG trial, the result was exactly the opposite. So patients were randomized to chemoradiotherapy using gemcitabine, the blue line, and chemotherapy alone, the yellow line, and there was a statistically significant survival advantage for upfront chemoradiation. So you can see that we actually reached nowhere with those 2 trials. Are there other trials? Yes, there are, but I think they are ancient enough that we can't really pay much attention to them. The North Castle Central Group from 1981, you're all aware of this, that showed an advantage to chemoradiotherapy. MD Anderson did not actually show any difference. The gastrointestinal study group showed also improvement for chemotherapy, for chemoradiation. And the last one actually showed minor improvement. This is the newest, which is 10 years old. So I'm not sure how much we can actually put weight on those trials. What we've learned from retrospective studies, that patients who actually receive upfront chemotherapy for locally advanced pancreatic cancer and do not progress, those patients, if they are given chemoradiotherapy later on, they do better than if you continue with chemotherapy. And that's from retrospective studies. This is a French retrospective review, and it shows you an improvement in the progression-free survival and an overall survival for those who were given upfront chemotherapy, had responded or stayed without progression, and then they either received chemoradiation or chemotherapy. And in this case, chemoradiation fared better. But remember, this is retrospective data. So this is the data, and this is another data shows that chemotherapy followed by chemoradiation had a better overall survival than upfront chemoradiation. So at least in those two retrospective studies, giving upfront chemotherapy followed by chemoradiation for those who do not progress have a survival advantage. But those are all retrospective data. So the LAB-07 trial came to actually delineate if this is true or not. And the LAB-07 examined two questions. Is giving chemotherapy for 4 cycles, and those who do not progress, you give them chemoradiation versus continuing chemotherapy, does this really improve survival? And whether adding erlotinib, the blue line, improves survival. So the erlotinib result came negative, and I'll show you here the result of the chemoradiation versus chemotherapy. And you see there is no difference in the overall survival between continuing with chemotherapy alone, the green line, or continuing with chemoradiation. There was a minor trend to improvement with the chemoradiation, but this did not reach statistical significance, and overall survival was the same. So I think the conclusion in this trial is systemic therapy should be the standard of care for patients with locally advanced pancreatic cancer. But now, we really do have a very good chemotherapy, so I don't think we should stop there. You're all aware of the FOLFIRINOX data with improvement in survival in the patient with metastatic disease, and an excellent response rate, as you can see, 31% as compared to 10% with Gemzar. And also we have the data of the IMPACT trial looking at nab-paclitaxel versus Gemzar, improvement in survival compared to gemcitabine, and also an excellent response rate, 23% as compared to 7% with Gemzar. So can we apply those to the locally advanced and see how it works? And I think the best way to look at it is to look at the latest meta-analysis that has been done, and that was published about 5 months ago. And this is for FOLFIRINOX-based neoadjuvant therapy in patients with either borderline resectable or unresectable pancreatic cancer. The group looked at 13 studies, about 250 patients. And you can see that the resection rate was 43%. And I put for you here to remind you with the previous slide that I have, and I know you cannot see it very well, but I will remind you that the R0 resection in the previous studies, in the previous meta-analysis, was 26%. The R0 resection here is approaching 40%. The R0 resection in borderline resectable, which is this group that we looked at, and which was about 26%, here 63%, and in unresectable, even those who were deemed unresectable upfront, we have more than 20% R0 resection. So those are very encouraging data. Toxicity was very much tolerable. You can see that with all those trials, you have the highest diarrhea is 18%, and the highest febrile neutropenia is 17%. And those are not actually high for such a bad disease. So data on nab-paclitaxel in the locally advanced is actually lacking, but we do have 2 important trials that are ongoing. One of them is in locally advanced, where you give 3 months of nab-paclitaxel, then you randomize the patient to chemoradiotherapy, 2 different doses versus continuing chemotherapy, and I thought we have answered this question before. And the second one is actually also locally advanced pancreatic cancer. This is the SCOUT-2 trial, 3 cycles of gem-nab-paclitaxel, and then patients are randomized also to either continue chemotherapy, but very strangely, you you continue with GemCap, not with nab-paclitaxel, or you give chemoradiation and 2 different doses of chemoradiation, and also there is another randomization giving the patient nalfinavir or no, and this is an antiretroviral agent that's approved for treatment of HIV infection that have shown that actually improve chemosensitivity or radiosensitivity in those group of patients. So my conclusion is a patient with borderline resectable or locally advanced pancreatic, unresectable pancreatic cancer may be offered FOLFIRINOX neoadjuvant chemotherapy if they have a good performance status. Regardless, even if they don't have good performance status, I think the way to go, according to the literature that I have read, is with chemotherapy alone. The role for radiation therapy in borderline resectable or locally advanced unresectable is yet not determined, and you can see that there are still ongoing trials trying to address this issue. Patients with borderline resectable or locally advanced unresectable should be assessed for resectability at several time periods. I've shown you that patients who were deemed unresectable upfront and received FOLFIRINOX, about 22% of them had R0 resection, and the role of nab-paclitaxel in the neoadjuvant setting is yet to be determined. Personally, I would prefer, if the patient has a good performance status, that he should go for FOLFIRINOX rather than for nab-paclitaxel. I think I'll stop here, and I'll be ready to answer that question. Thank you for your listening.
Thank you for your elegant presentation and informative presentation. I may ask about what is the percentage of resectable lesions converted to be resectable lesions in this protocol?
Okay, so if you look at the first meta-analysis, the resectability and R0 resection, what count? It was 26% in patients who were borderline resectable. And borderline resectable, when the surgeon tells you this is borderline resectable, it means he is likely to get a positive margin. So in the older studies, it was 26%, the R0 resection. Those were initially borderline resectable. However, in the FOLFIRINOX, as I showed you, those who were borderline resectable, resectability R0 was 60%, and in the unresectable was 22%.
What about the R1 resection? It is microscopic involvement, or R2 macroscopic involvement?
Right. I haven't looked at that. I think it's probably there in the first meta-analysis, but I really did not look at it because it doesn't count. What counts actually is to get an R0. So there's a very nice graph that I did not put here for the sake of time, which showed you the survival of patients with pancreatic cancer post-resection correlate with the margin. If you have a negative margin, that's the best survival. If you have an R1, you have a lower survival, and if you have R2, most of those.
No survival, yeah. Thank you for your excellent presentation. Thank you.
Thank you.
Yeah.
How long do you? For how long will you give full FOLFIRINOX? And what is the cutoff point when this, when the tumor will be away from the second ear recipient?
Well,
for how long will you give that?
To start with, in the metastatic disease.
No, in the local.
Right. I'm reaching there. FOLFIRINOX was given for 12 cycles, and those who actually have used FOLFIRINOX know that you cannot really go beyond 12 cycles in many patients because they start to get side effects. In patients with locally advanced, you would probably go all the way to 12 cycles, but those patients should be assessed for resectability at different time points, even if they were deemed unresectable upfront. So the surgeons have to look at them from time to time to see if there is any resectability. In the latest meta-analysis of FOLFIRINOX data, patients who were deemed unresectable, 22 of them, 1/5, were actually zero resection. So I think that has to be looked at from different time points. I personally go for 12 cycles, and if the patient is still responding or stable disease, I'll give them maintenance Degramo or
Do you have cycles every weekly or something?
For FOLFIRINOX, every 2 weeks.
Every 2 weeks?
Yes.
So you give 6 months.
So 6 months of therapy. Yes.
Do you assess the response after 4?
After every 4 cycles. So every 2 weeks. Yes.
Thank you very much, Dr. Shah, for this nice presentation. As you mentioned, performance status is a key in determination of which regimen to go with. So XLMPS 0 and 1, when you go for FOLFIRINOX, if more than this, i.e. performance status 2, then you may go for single agent gemcitabine also. Is there any room for doublets rather than triplets? So you may go, for example, for FOLFOX, FOLFIRI, something like this for those with PS2 or those intolerant to FOLFIRINOX?
Absolutely. The data, and apologies that I did not put it clearly from actually the initial meta-analysis that I showed you, that patients who have combination chemotherapy, they do better than those who actually have single agent. So if you have somebody with locally advanced who has performance of 2, you cannot give them FOLFIRINOX, then those patients should actually go on combination chemotherapy rather than single agent. However, with combination, I wouldn't go for FOLFOX. I would probably go with more of either gemcitabine, capecitabine, or GemOx or whatever. But I would not go only for gemcitabine alone.
Thank you.
For the sake of the time, thank you very much, Dr. Shawi, for this nice and very interesting presentation as you know.
Our next speaker will be Dr. Tariq Shaman. He is my best friend and my dear colleague, and he will talk to us about the scheme-tactic polyradiotherapy in HCC.
Good morning, chairpersons, my colleague. It's my pleasure to chair in this elegant meeting. My presentation will be about the evolving role of external beam radiation therapy in the treatment of hepatocellular carcinoma, which is a major health problem worldwide. It's known to be the 6th most common cancer in the world and the 3rd leading cause of cancer deaths. In Egypt, it's now on the top of cancer in males, especially in males. 85% of cases occur in developing countries, mainly Africa and Asia, and very astonishing that it's in the United States now it is the fastest growing cancer and it makes a major problem there. We know that the Barcelona Cancer Group staging and guidelines, which give us that early stage in hepatocellular carcinoma, stage 0 and stage A. This is the only category that are curative, that when they are treated, they have a curative intent, with 5-year survival about 50%, using either local resection. If not, they go for transplantation. If not indicated for transplantation, they go for radiofrequency. For intermediate stage with good performance, child A, child B, the major treatment go through TACE, which is some sort of preventing disease progression with a median survival around 20 months. For the advanced stage C, but still the patient has a good performance, child A and B, there is still a room for targeted therapy like the sorafenib, which gives a median survival of 10 months. For the more advanced cases with bad performance, child C, they are treated on a palliative intent with very low survival, less than 3 months. Radiotherapy has limitations in the treatment of liver cancer because of many problems. If you are intending to treat the whole liver, it's known that the tolerance is very low. It's less than 28 gray, which is not enough for hepatocellular carcinoma or liver mets. If you are intending to treat partially the liver, we have two factors which are challenging for external radiation, which is the movement of the liver with respiration, which make the target moves during the treatment, and the nearby sensitive structures you have to avoid, and you have to prevent toxicity from extra dose, including luminal organs like duodenum, stomach, or sensitive organs like the spinal cord and the kidney. The toxicity of whole liver irradiation is called radiation-induced liver disease. Clinically, the patient presents with he has hepatitis, fatigue, elevated liver enzymes, especially the alkaline phosphatase. He has tender anectric hepatomegaly and maybe ascites. The pathology which happens, mainly it's like veno-occlusive disease. The liver toxicity, usually it's not an acute, it usually occurs more than 2 months after radiation, and it is treated like hepatitis with supportive treatment, which may progress to liver failure. The technical development of conformal radiotherapy in the 80s initiated the re-interest in the treatment of primary and metastatic liver cancer with radiotherapy. The recent advances in external radiation allow for more accurate targeting, make aggressive dose fractionation strategies possible using techniques like the stereotactic body radiotherapy, which was originally used in intracranial, and sometimes it's named radiosurgery, because the aim is to get radionecrosis in the tumor like you are doing surgery. Then, after the adaptation of the technique and the intracranial, they started to reuse it in body tumors, and the liver tumors, one of the indications. The SBRT in liver was pioneered by Dr. Blomigan at Karolinska in the early 90s, using conformal therapy even before the evolving of IMRT and IGRT. With the new technology and the trials used the new technology, the incidence of RILT was uncommon. The definition of stereotactic body radiotherapy is external radiation therapy used to very precisely deliver a very high dose of radiation to extracranial target within the body, using either a single dose or a small number of fractions ranging from 3 to 6 fractions maximum. This is the, what does it mean, dose distribution. We can see that this is the tumor with lipidol inside. This patient was done after TACE. The edges of the tumor receiving the high dose, 40 gray over 5 fractions. The inside of the tumor receiving even higher dose, up to 50 gray. And there is a very sharp steep down of the dose in the outside, the target outside normal structures. The advances we got in radiation technology has many challenges to overcome. First is the accurate target identification, which give you a very precise margin, so you don't need to use a larger margin. By using the triphasic CT in the planning, you may use MRI and PET CT for more identification of the target or identification of other tumors not seen by the CT, and the use of what's called gold fiduciary markers, which now are used to track the tumor during treatment. There are also many procedures to account for the organ motion during respiration, as we said. We have now what's called the 4D CT, which you can take CT images during inspiration and expiration. So you have a very good images to delineate the targets. You don't have distorted images because you are taking during respiration. You have a breath holding techniques. You have the abdominal compression techniques to limit the movement. And you have also the technique of respiratory gating, which gives the radiation during one phase of respiration and radiation off during the other phase of respiration. All this treatment can be done through sophisticated treatment delivery. The patient can be treated with conformal radiotherapy, can be treated with IMRT, can be treated with arc therapy, or machines like the Cyber knife, which is a combination of cylindrical volumes and robot. The indication of either treatment delivery depends on the setup you have in your department and the patient and the tumor criteria. For treatment planning, as we said, we use the triphasic CT, best seen in the arterial phase. If you have 4D CT, it gives you more better images. If you don't have a 4D CT, you choose to take the images under breath hold. You ask the patient to hold the respiration, preferably end expiration. If the tumor is not clear in the CT, still you can do MRI, PET CT, and do fusion. As we see here, the tumor is more well defined in the MRI. Studies were done to estimate the motion of the liver and how much the margin you have to use or you have to put it into consideration. One of these studies showed that the craniocaudal motion, on the average 8 millimeter, and for the anteroposterior motion it is 4 to 6 millimeter. For the lateral motion there is 4 millimeter. This is on an average patient. As I said, organ motion must be accounted for because you have to be sure that your target is covered by the high dose you are prescribing. All the setup in each fraction must be inside the high dose area, and the normal tissues has to be outside the high dose region. For organ motion, you have to do procedures for motion restriction, and you have to have procedures to estimate how much the movement is with each patient, so you put a margin for consideration of these movements. the motion management, we have two techniques: respiratory gating, abdominal compression. Abdominal compression is with each setup you do the maximum tightness of the abdomen of the patient he can tolerate, and it shows it reduces the movement about 50% than a normal situation. And this is the most used technique with SBRT. The respiratory gating is somehow a very complicated technique, needs good cooperation of the patient. And this technique usually done for conventional treatment, the patient when treated on long duration. This is the way how we do the abdominal compression. The patient lies in fashion, and we do abdominal compression by abdominal belt, or we can use very tight mask to take the shape of the compression. This is what called fiducial markers. This is also a new evolution in target tracking during treatment. They are inert and they are implanted in the liver around. They don't need to be inside the tumor. They can put around the target. Some centers they do is they add 3 markers. Some they can add 5 markers. These markers, you can see it in the CT and the MRI. This is an example of patient where one of the marker, but it was put inside the tumor. And this is for the setup of the patient. The cross are the centers and the centers of the fiducial, and it's not very clear from away. We measure the shift of the center from the fiducial markers, and we do before each treatment we do resetup of the patient on the accurate position of the markers. The literature now is very rich in data about the critical structures tolerance dose, because the old literature was mainly concerned with daily fractionation of 2 gray, but the use of high fraction dose like 20 gray single fraction or 50 gray over 5 fraction, it was not known for what is the tolerance of the stomach, what is the tolerance of the duodenum. So we have now a good literature describing the tolerance dose according to the biological effective dose with the daily fraction of 2 gray. So this technique, in summary, is generally a frameless setup. Now it's frameless because when they started as a frame technique like the intracranial, but with the new technology, it's free setup, frameless. We delineate the target, as I said, on CT or MRI, and the CTV equal the GTV. We don't add a margin for clinical target volume. Then you add a margin for the setup errors, including the motion movement. We have to estimate in each patient. It ranges from 5 to 10 millimeters according to the direction. And we have to prescribe the dose. When we mean we prescribe the dose at 70 or 90, we mean that the dose inside the tumor has to be larger than the edge, which reaches to up to 130 of the prescribed dose. So if your prescription is 50 gray, inside the tumor it can be 60 or 65 gray, which causes necrosis. You have to have also image guidance on your treatment machine to verify setup with each fraction. This is an example for this patient. He has 2 tumors. Each tumor was less than 6 millimeter. We can see that You can see that this is the GTV, and the edge of the red was called the BTV, where the prescription is done. The red area is the prescription, the dark red, which is the higher dose inside the GTV, and this is the 80% of the dose. And this is those volume histograms for the target and the normal structures. All they have to meet the constraints we put according to the tolerance of the tissues. This is a case done on the Monaco treatment planning system. We are using 9 feeds IMRT. We can see that this is the 15 gray out of prescribed dose 40 gray, which meets the tolerance of the rest of uninvolved level. This is how we put the constraints and we evaluate this planning is fit for this patient or not. Not each patient is indicated for SPRT because these patients they can be treated with radiofrequency in some patients or SPRT. So these hatched lines are the areas where radiofrequency is not usually done because of the subcapsular or nearby vessels. And the area, but this area can be used for SPRT. The area inside can be used by SPRT or radiofrequency. But the most important that, which is one of the contraindications to SPRT, is how close the luminal structure from the tumor. By luminal structure, we mean the stomach, the duodenum, the esophagus. It has to be more than 1 centimeter in some centers, and other centers they put the limit of 2 centimeters away. So tumor in this site is not eligible for SPRT because the dose will be very toxic to the stomach or duodenum. The treatment results for these evolving techniques, in most of the literature, the aim was mainly local control and or it's as a bridge to transplantation. If the patient is indicated for transplantation and is in the waiting list, so they put the patient for SPRT until is on the list for the transplantation. The indications, as I said, can be stage A and B with good performance, child A and B. For patients ineligible for surgery, either medically inoperable or if the patient or if the case is central, which is surgically inoperable, or ineligible for radiofrequency with a size more than 3 centimeters, or as I showed, the location is contraindicated for the radiofrequency. For the SPRT has to include lesions less than less than 3 lesions. The diameter of the largest lesion not more than 6 centimeters, or some centers they do criteria that you have to save about 700 cubic centimeter of uninvolved liver to receive the tolerance less than the tolerance dose of the liver. So you can save about 700 centimeters of the liver. And of course you have adequate liver function and life expectancy more than 3 to 6 months. This showed the trials for hepatocellular carcinoma. They are not so many. Most of them they are phase 1, phase 2, but we can see that they have some encouraging results. We have 1 year survival around between ranging from 48 to 75% using single fraction or hypofractionation in 3 or 5 fractions. They also, some of these trials included patients with liver mets from other primary, and they showed also, they were mainly from primary rectal carcinoma, and they showed also good local control, around 70% to 86% in some series. This also other retrospective and phase 1 studies, many of them showing median survival above 20 months, which is comparable to this, or sometimes it's more than the median survival given by the DTs. This study presented at the ASTRO 2012, and the mean tumor volume included was 33 cc, and for child A patients, the 2-year local control was 87%. For child B, the local control 85%. You can see that the prescription dose is less than in child A. This also multi-center trial using the same indication for patients eligible for surgery in a good performance child A and child B, and we can see that the 1-year survival also is 87%, and they included also some intrahepatic cholangiocarcinoma, which the results in the 1 year is around 48%. This is also another study, about 60 patients, for patients eligible for surgery, with a median follow-up of 27 months. The 2-year local control was 90%, when overall survival was 48%. This slide shows very interesting case in the previous study. For this patient with large central tumor, and he has satellites subcapsular, and this tumor was infiltrating the portal vein, so he was not indicated for DTs. This patient was treated with SPRT for the central mass, although this is out of the usual indication of SPRT. So he got resolution of the unpainted portal vein, and after that the patient could receive this treatment. So this could be one of the indications can be used to prolong survival in these poor patients. This is also a case where this tumor is not amenable to radiofrequency or surgery. It's infiltrating the vena cava, but it was well treated with SPRT, with very good dose utilization and sparing of most of the normal level. The competitive treatment now, which is the TACE, I showed you this table to show the median survival with this technique. It's also ranging the survival at 1 year, ranging from 24 months up to the 1 year, 24% up to 50%. There are two important phase 3 studies running now to address certain points in this technique. One is the R2G trial, which showed that SPRT, according to the previous phase 2 studies, improved the local control. So they added sorafenib in addition to the radiation against sorafenib only, and we are waiting to this result to see that the survival will improve with adding sorafenib 4 times. Another study run by the International Atomic Energy and our institute, one of the centers, there are 10 centers using the same indications of patients unsuitable or unwilling for surgery for child A and B, and patients are randomized between SBRT or TACE, because this is the first phase 3 study to see if SBRT is equal to TACE or superior. So in conclusion, the integration of new technologies has raised the interest on external radiotherapy